talking about those portal cable anastomoses that were important. Did anybody think about what kind of surgical intervention you might use in a severe case of portal hypertension?
Shunts?
What would you connect?
The splenic,
On this?
splenic to the inferior vena cava?
Well, to the left renal vein,
Yeah.
right? So there's a splenorenal shunt. Take out the spleen, connect the splenic vein right to the left renal vein. So splenorenal shunt. Anything else? Where else might you connect? Might be a mesocable shunt. So take that superior mesenteric vein and connect it to the inferior mesenteric. Or maybe even some type of direct connection from your portal vein to the inferior vena cava. Right? They're in proximity to one another, but as we're just at the inferior aspect of the liver. There's a procedure that radiologists use inside the liver to connect portal vein branches to inferior or to hepatic vein branches. It's called the TIP procedure, transjugular intrahepatic portosystemic shunt. But that apparently is a great favor. So they can go, with the help of a radiologist inside the liver and actually connect those two structures with a shunt. There's even a procedure to take that greater omentum, that omental apron, and suture it to the inside of the anterior abdominal wall. And then over time, you establish connections between your systemic drainage in the anterior abdominal wall and the portal system that's draining that greater omentum. So there's a lot of different ways to connect those surgically if you had to. Okay, gallstones, choliasis. What spinal cord levels would be involved in innervating the gallbladder? So what are we talking about here? Are we talking about somatic innervation or visceral innervation?
Visceral.
Visceral, so autonomic, parasympathetic or sympathetic?
Sympathetic.
So it's hard to know what the parasympathetic supply to this structure might be, but under conditions of vagotomy, it tends to swell a little bit. So, so it might help a little bit somehow. But sympathetics are important for vasomotor control in this area and for pain, right? So sympathetics are responsible for the pain. So what spinal cord levels did they decide would the sympathetics be taking back from what spinal cord levels? Where would we enter?
The sympathetic?
Yeah, where would those pain fibers end up in the central nervous system? What spinal cord levels?
No.
No, lower.
You're getting close, right?
11 and 12. What's up, guys?
The greater sympathetic.
T6 to T9. So, greater thoracic spine.
Oh, wait, your hands
No,
are
it's plain.
reading.
I always
Okay.
put it plain on the name.
So referred pain is going to be visceral pain referred to the body wall. So the central nervous system is confused, mixes up that visceral pain is doing somatic pain. So we're not firing off those somatic nerves, but it's misinterpreted as coming from that particular portion of the body wall. So this would be the T6 to T9 on that right side. So that explains that dermatome map that you looked at and where in relation to T6 to T9 you might experience pain from the gallbladder. Where's the fundic portion of the gallbladder on the anterior abdominal wall? What landmarks? These are the kind of things you should be thinking about when you're thinking about structures.
Yeah, like,
How does it project to the anterior abdominal wall? What vertebral level?
Inferior level of the liver.
Fundic portion of the gallbladder.
so
Tip of the ninth costal cartilage.
Isn't it?
Tip of the ninth costal cartilage. So when you've got that costal arch, you've got the tip of the ninth costal cartilage on that right side. That's where the fundic, so it touches the anterior abdominal wall there. Right? What plane is that? These are the horizontal planes that we can divide up this anterior abdominal wall into regions.
periumbilicus?
Transambilical.
Oh.
What vertebral level is it? L1.
L1, yeah.
Okay, so you get a lot of information just from thinking in terms of these planes, what's located at that. Anything else at L1?
Pyloric sphincter.
A lot of things, right? A lot of things.
First
First
part of the
Tyler
First
Spencer.
part of duodenum. Duodenum begins at L1, ends at L2, but it's almost 12 inches long. It just curls back.
Yeah.
Tail of the pancreas? Is that that one?
No, it's over by spleen. It's a little higher. The hilum of the kidneys. A little bit. We'll talk about that next week. Conus medullaris.
You mean tomorrow?
Yeah, that's right. Okay, hiatal hernias we talked about already. That we have these two different types: type 1, type 2, slider and periesophageal. It's pretty straightforward. Let's move on to this week's. Okay.
Are these on black? Dr. Sarah?
Yes, they should be.
Oh, no. Oh, that was lab 9.
Yeah, I had up till.
No, that's the same one you just said.
I think you accidentally closed the other one.
Yeah.
There you go.
See, 10.
All right.
Dr. Karen, can I ask a question real quick?
Yeah, right.
So we were just doing the, in the dissector today, because the pancreas is L1 to L3, but it's higher than that, the dissectors?
It just arches across. I mean, it's notched into the, when you think about where its head is located,
In the
Right.
duodenum.
so it's not just at L1. That's my point.
Right, right. But the tail is the highest part, so I thought that would be at the L1 level. But
That's a little bit higher up.
It's higher than that? Okay.
Well, I mean, it's under the diaphragm, it's tucked, right with the spleen.
So maybe it's just it's L1 to L2.
12 point.
I mean, a portion of it has to be at L1, just because of the way it's coming across. But when you think about major structures at that level, think about, the big things that are right there. I mean, transpyloric plane, at least in a cadaver, in a supine position, with somebody fixed like that, the pyloric portion of the stomach would be held. But with gravity and standing up, that's supposed to descend right there. So it's not going to be held. The pyloric portion won't be
Oh my god.
Something is in the ceiling.
It's above us.
Yeah.
Oh, it's a mouse.
There's a mouse in this house.
Sounds more like a rat.
Okay, so here we have, what are diverticulosis, diverticulosis and diverticulitis?
Pouchings from large bowel inflammation.
So we have a diverticulum letting out, little bulge coming out of the side of the wall. And where would they be located?
The left quadrant.
Mostly in the
What
colon.
particular portion of the GI tract?
Sigmoid is common.
Quite often sigmoid colon, so large intestine. almost always. Pretty rare to have it in the small intestine, possible, but pretty rare. So large intestine, and oftentimes sigmoid colon, why? A lot of pressure, because there's a very small diameter. That's the smallest diameter of the large intestine is in that sigmoid colon area. So intraluminal pressure can be quite large there.
Look at that.
So what's happening here when we have a diverticulum, it's diverticulosis, what's happening? Well, here's an example, you've got some here, letting off the side of the sigmoid colon here.
Material got caught in the little pockets.
And then get infected bacteria can feed off it.
Yeah, so they can become inflamed, right, so they can become infected.
And they can perforate.
But what's happened, we've had actually mucosa and submucosa come up through the outer layers. So it's coming up through the muscle and connective tissue layers, right? It's bulging up through.
Like a herniation.
Yeah, so it's herniated up through.
Yeah.
And so the large intestine, it also makes sense because we don't have a complete outer layer of longitudinal smooth muscle, right? So we don't have the same protection that we do along the rest of the GI tract. So the tinea coli are these layers of outer longitudinal smooth muscle that are coalesced into these three distinct bands. And what you'll have too is not only that less muscle that's protecting that, but you'll have nutrient vessels that are penetrating through that intestinal wall, and they're creating essentially little points of defects also in those areas. So there's possibility right where those nutrient vessels come through that you could get a diverticulum coming out. So And diverticulitis, and we already said would be
Infection.
an infected site. And what are some complications of diverticulitis? Fistula is possible, sure.
Perforation.
Could be done.
Perforation.
Perforation, yeah. I mean, so they're serious. Bleeding, all these things that could happen. So very serious condition really that has to be managed. How to manage it is controversial a little bit. They used to say, you need to have high fiber. That's the case. Anyway, Meckel's diverticulum. What is that? This is some understanding now of development. What is a Meckel's diverticulum?
Doesn't develop correctly, like it twists the wrong way, or is that
It's
something?
a retention of what structure? Here's a Meckel's diverticulum. It's also called a yolk stalk.
Oh, yeah.
It's also called a vitelline duct or vitellointestinal duct. The yolk sac in development is actually incorporated, at least a portion of it is incorporated into the developing embryo and forms the primitive gut tube. So this vitelline duct was the connection to the rest of the yolk sac from the gut. So it's along the midgut. And so that could be retained. If it's retained, you could end up with some problems. So there's all these rules of twos that apply sort of to this. That it affects maybe 2 to 4% of the population. That it's usually within a couple feet of that ileocecal junction. That it's oftentimes only about 2 inches in length. 2% of the population are symptomatic, so most of the people have it and don't realize it. There are 2 types of ectopic tissue, so it's got all the tissue characteristic of that part of the GI tract, but usually it also has maybe some pancreatic and some gastric tissue in that particular Meckel's diverticulum. Happens twice as often more in males than female, and clinical presentation is the most common in 2 of those. So, but you could actually have these complications here, and it would obviously go and connect normally to the backside of the umbilical area, right? Because this would actually be going out the umbilical cord toward the yolk sac. Okay? Any questions about that Meckel's diverticulum?
Basically like having a second.
Hirschsprung's disease. Anybody read about what that is?
The entire nervous system is not developed.
This is where you have failure to colonize a portion of your GI tract, usually at the large intestine, with neural crest cells. So you actually get a portion of this large intestine that's not innervated, doesn't have the enteric neurons there for the digestion to take place. So there's no peristaltic wave in that section. So what happens is fecal matter comes up to that denervated section and backs up, right? So you get this megacolon. So Hirschsprung's disease is aganglionic megacolon. So it's a particular type of megacolon where during development you didn't get colonization at that particular portion of the GI tract. Usually affects the rectal area, and maybe in 80% of the time all the way up to the mid-sigmoid colon area, and less often than does it affect more of the large intestine. Maybe 10 to 20% of the time it might do the ascending colon and transverse colon, but it rarely makes it over to the right side. But serious, so the colon becomes gigantic, above, proximal to this denervated segment. But there are other conditions that could cause megacolon. So this is Hirschsprung's, aganglionic megacolon. So tomorrow I'll ask you what other conditions might cause megacolon. And what's the last one? Oh, we've got malrotation of the gut and volvulus. So let's take a look at this real quick at these, and then you guys can go. Rotation of the gut. So during development, we have rotation of the gut, right? We divide the gut up into the foregut, midgut, hindgut. Foregut undergoes clockwise 90 degrees rotation. So you get the gut tube, and it rotates 90 degrees clockwise during development. And you've seen evidence of that already. You had your left and right, vagus nerves along either side of the esophagus and the thorax. What happens as they get down towards the diaphragm?
They go anteriorly and posteriorly.
They recoalesce, so they're forming this esophageal plexus, and as we get towards that esophageal hiatus, they actually are positioned now anterior and posterior on the esophagus. So that's part of this rotation that's taking place, 90 degrees clockwise rotation that happened. Midgut undergoes what? Also undergoes a rotation.
270 degree rotation?
270 degree rotation in total. So quite a bit, huh? So midgut grows so fast that it actually ends up herniating out of the abdominal cavity during development. It goes into the umbilical cord. But you end up with this midgut loop that has a cranial and caudal limb to it. And the cranial limb consists in, what's our midgut in total consist of? When you think of the canal.
The small intestine up until the 2/3 of the way across the transverse colon?
Yeah, but what part of the small intestine, how much of the small intestine, all of the
No,
duodenum?
The last part of the
the
duodenum,
duodenum.
So about the distal half of the duodenum.
and all of the small intestine, and the ascending colon, and 2/3 of the transverse colon.
So cecum, appendix, the ascending colon, and maybe 2/3 of transverse. So that's all. So if we put that into this, we have a cranial limb. This would be the distal part of the duodenum, okay? Jejunum, and then ileum coming across, still ileum here. We'll make that over here then, that ileocecal junction, where we have the appendix over there. Then we have ascending colon, right? And then part of our transverse colon. So the midgut herniates out like that, and when it's in the umbilical cord, it undergoes a rotation. And if I'm looking at my gut rotating, it's 90 degrees clockwise, just like the foregut was. But now we're out in this plane, instead of looking down, we're in that anterior posterior plane. So it undergoes that 90 degrees clockwise rotation. And then as it's entering back into the abdominal cavity, it undergoes an additional 180 degrees rotation. So if this is that's still our, appendix here, let's say. So just a part of the ileum here. We're coming back in. You can see what's happening then as we're coming back in. The duodenum is getting pushed way to the back. Right? Appendix is coming over onto the right side. Transverse colon coming transversely across here. So everything ends up back, in the abdominal cavity where it should. But if you get any kind of malrotation, things can be, this can happen during development. You could end up with only 90 degrees rotation. And that 180 degrees rotation, additional to that, never happened. So it just comes in like that. So what happens? Just remember is duodenum, jejunum, and ileum. That's all on the left, all on the right side. And we have colon all on the left side. So you end up with this left-sided colon in that case. Everything's packed into the left side. It's all large intestine. Then we might have a situation where we have reverse rotation. What happens usually is you get that 90 degrees clockwise rotation, that's fine. But the 180 degrees rotation doesn't go in the right direction. It goes in the opposite direction. And what happens then? We end up with the duodenum
In front
the
of
transverse colon is pushed to the back, right, as it comes in. And the duodenum and the jejunum are in front of it. So you're getting that here, in front of the transverse colon. Okay? You could have it in a whole situation where everything is entirely reversed. So instead of going at 270 degrees in that clockwise rotation, when I'm looking at my gut rotating, and that causes some problems when people read it in these embryology textbooks. They talk about the foregut rotating 90 degrees clockwise, and the midgut rotating 270 degrees counterclockwise. But that's if you're looking at it. And if you're looking down at your own gut rotating, your foregut and your midgut are rotating in the same direction, essentially. It's just in a different plane. Anyway, you could end up with 270 degrees in the other direction, and you end up with the situs inversus. You end up with everything reversed. And so that was this. Everything is reversed. It could be complete or partial. So everything could be reversed in the thorax as well as the abdomen. And finally, lobulus. So here would be a situation where you don't have structures adhered properly to the posterior abdominal wall. You might have an excessive sigmoid colon that's very loosely attached, could twist on itself. Things are pretty mobile in there, so if things aren't positioned properly and fixed properly, if you get excessive rotation, you can end up pinching that off, obviously. You not only occlude it, but you end up blocking the blood supply and it becomes ischemic. So a very serious condition, obviously, could become gangrene and infected. Same thing could happen here in the small intestine, might not be bound down appropriately with that dorsal mesentery, could become too free and loop on itself, twisting and causing this condition called Novalis. Okay? Tomorrow we finish up.